Ladies and gentlemen, thank you for your patience in holding. We now have your presenters in conference. Please be aware that each of your lines is in a listen-only mode. You may submit your questions electronically at any time during today's presentation by using the Q&A window located to the left of your slideshow presentation. Underneath that, you'll find a resources window where you may download handouts for today's presentation as well. It is now my pleasure to introduce today's first presenter, AHA moderator Susanna Hopf-Zollern.
Thank you, David. Welcome, everyone, to today's webinar. I'm Susanna Hopf-Zollern with the American Hospital Association. I'm pleased to be moderating today's webinar, Creating Health-Based Solutions Around Community Violence. Detroit Life is Valuable Every Day, or DLive, is a hospital-based violence intervention program at the Detroit Medical Center Sinai Grace Hospital. DLive was created to address the alarming recurrence cycle of violence among youth and young adults seen in a major Detroit trauma center. DLive's work is rooted in addressing violence with a health-centered approach, an approach that is designed to improve individual and community health by implementing innovative, evidence-based strategies for preventing repeat injury, death, and the associated community toxic stress associated with violence. During today's webinar, you'll learn how a small team at Sinai Grace Hospital, the emergency department, and the surrounding community work together to address the social determinants of health surrounding community violence. Our webinar will begin with a presentation, and we will conclude with a 10 to 15-minute question and answer session. If you have questions at any time, please type the question in the Q&A section on the left section of your screen. A DLive case study is provided in the resource section of your screen in the lower left-hand corner. Let me briefly introduce today's speakers. With me today is Dr. Tolulope Shinoui and Ray Wyans with the Detroit Life is Valuable Every Day DLive. Dr. Shinoui is an emergency medical physician and serves as the medical director for DLive. After taking note of the alarming recurrent cycle of violence seen in the ER with Detroit's youth, he founded DLive to address community violence with a dynamic health-centered approach. DLive's impact has been groundbreaking, and they've been the recipient of notable awards and recognition. Ray Wyans served as a community organizer for the City of Detroit's Violence Prevention Program, Operation Ceasefire. In this role, Ray provided critical gang intervention expertise and training for other outreach specialists. This work eventually led Ray to seek additional experience in the field of trauma. And as a result, he was led to DLive, and his impact was immediate as he became Chief Violence Intervention Specialist and Vice President Community and Communications. And he created innovative strategies to deepen and broaden the impact of DLive's violence intervention work. It's now my pleasure to turn the program over to Dr. Shinoui, who will begin our presentation.
Hello, everybody, and thank you for that wonderful and kind introduction, very thorough. My name is Tolulope Shinoui, as was mentioned, an emergency medicine physician here in Detroit at Sinai Grace Hospital, Detroit Medical Center, and I'm joined by my partner and just incredible individual by the name of.
Good afternoon, everyone. My name is Ray Wyans, and thank you for joining in. And hopefully, it's very insightful.
Absolutely, absolutely, and welcome in a virtual way. Welcome to Detroit as we go and talk about some of the items that are outlined here. As is customary, we want to just make sure that we thank you guys for joining us. Definitely humbled and flattered that you guys would join us. Want to kind of go over just briefly some of the objectives that you guys saw, I think, already when you registered. But just to reiterate them, we're going to learn a little bit about how to initiate a health-centered effort around community violence. We'll go ahead and share some strategies that we've used that we've seen to be effective in terms of building effective community partnerships and addressing some of the critical drivers of community violence. And then learning of ways to create platforms for community voices to be centered and heard. We look forward to the questions, and really this is a discussion, and so we look forward to having a good time and learning from you all as well. Okay, so just part one here. Now this presentation would be absent without recognizing the historical role that violence has played in terms of where we're at locally here in Detroit and really nationally. And this slide right here is to really highlight one of the first studies from a trauma standpoint, a trauma surgery standpoint, that really quantified how violent disease works. I think the title says it all, urban trauma, chronic recurrent disease. This was a study that was performed here in Detroit in the 1980s and involved, at that time, about 5 medical centers. And what the study showed was it really outlined this concept of trauma recidivism, that once somebody's injured, there's a very high risk, a very high chance of being re-injured again. And it was really a study that served as a landmark study for other centers to really show and illustrate how violence behaves in many a way similar to items such as diabetes and heart disease when left untreated. And it really was, it's been pivotal in terms of making the case for violence to be considered as a public health issue. And this was, again, back then in the 1980s. And when you really look back at it, even as early as the early 1980s, you had our previous Surgeon General, Dr. Everett Koop, talk about violence in public health and the role that violence was playing in the health of our nation and as a community. And at that time, he was really focused mostly on domestic, child, and sexual violence. But nonetheless, just this concept of violence and how that played a role in terms of us as a public health community. And we've even had the World Health Organization chime in on this as well. So a very important issue, and we just wanted to open up this slide with just the root and really center what we're talking about when we're talking about violence. Because when we're talking about violence here, what D-Lab does, we're really focusing on this concept of community violence, direct intentional violence that's interpersonal between individuals in the community. And you'll see that picture up to the right with those young individuals there. Again, just showing that despite this study taken back in the 1980s, it's still an issue that remains persistent and prevalent and relevant here today. This next slide here shows exactly where we're at right now. This is featured in northwest of Detroit. Detroit is a large city, and it's played its. We've seen how Detroit's kind of been discussed in the news in various capacities. Here at Sinai Grace Hospital, we are in the most densely populated section of Detroit, in northwest Detroit, and it serves as the primary place that people come to in this area for their care, whether it be cardiovascular work, OBGYN work, whatever it is. However, it does have the dubious distinction of receiving the most amount of penetrating trauma, more than any other trauma center in the state of Michigan. And in fact, when we refer back to that study that I just showed on the previous slide, Sinai Grace, which formerly was known as Mount Carmel Hospital and Sinai Hospital, and eventually came together and formed Sinai Grace Hospital, but those two hospitals were part of that study back in the 1980s. Again, okay, so it played a role in that public health sort of description about trauma being a chronic recurrent disease. And what we have found out now that we've done sort of an update, sort of preliminary analysis on that study that was done in the 80s, is that not much has changed. This trauma recidivism and this rate in terms of having a high chance of being injured again once you're injured, those rates haven't changed. At that time, they thought their results in their data showed it to be 44%. And what we have found now, even when we updated it now in the 2010s, is that rate is mostly unchanged. And that's because there's been there's been no systemic change of addressing the issue really until some of the efforts that we put together here with DLive. And so we wanted to share this this slide with you again, just to kind of give you an idea of the environment in terms of where we're at in Detroit. And when you talk about violence here in Detroit, it's the leading cause of death for young people here in the city between the ages of 15 and 34. So again, it remains a very relevant issue, not only here at Sinai Grace Hospital, but really throughout the city and in other similar communities throughout the state. And the understanding of violence is really requisite upon taking note of this social ecological model of health. And you'll see it described many a times, whether we're talking about sexual violence, domestic violence, or even community violence. And it's defined very well by the CDC. And this framework actually comes out of a paper that was by Frather and others that came out in the early 90s, I believe. And it really serves as a framework for understanding prevention in general. Again, whether we're talking about violence prevention or other forms of prevention. And when we look at these different levels here, whether you're looking at individual, interpersonal, organizational, all the way out to societal, it's really important to understand this as a framework of intervention for understanding the complex interplay between all of those levels there. And whether we're dealing from individuals or out to systems, we understand that they all play a role in terms of how violence is experienced, whether it's affecting you in terms of you being injured by it or being a perpetrator. And so understanding this framework allows us to move forward in terms of creating the right kind of innovative solutions that are going to be necessary in addressing this issue. And Ray could even speak to the interpersonal sector in terms of one of the first things we learned there.
So when we looked at the interpersonal, one of the things that we looked at was, from the socio-ecological model, was how big and how much of an influence that the individual who may have been exposed to the community violence, directly impacted by it, his secondary network, whether it be the grandmothers, the grandfathers, the friends, the cousins, and things like that. So actually a lot of our work transitioned through them. Because again, once a person comes to Sinai Grace Hospital, we truly understand that their safety has been interrupted with this act of violence. And so to be a complete stranger and to do a bedside approach sometimes can add toxic stress and just outright be uncomfortable, right? And so what we noticed was when we actually approached the families, it allowed us to easier access to the individual and provide actual better services for that individual. And through that work, what we've also been able to identify through the social network and the interpersonal violence is one individual may have been shot today, January 24th. When we take a look at a social network, he may have 10 other friends that had been shot within a course of the last 6 months. Some may have not survived the act of violence that was inflicted on them, right? But now that leads for deeper conversation and really understand the PTSD that's associated with it and their adverse childhood experiences and trauma as well.
Yeah, absolutely, absolutely. So yeah, it's definitely played a very key role, this framework, just in terms of understanding how we move forward with the work that we do. We'll kind of get into some of that a little bit deeper in some of the later slides. So building upon this slide here, when we talk about this framework of prevention, it really sets us up for this in terms of understanding really the title of this slide, right? Systemic problems require systemic solutions. You know, we've seen just so far in this presentation, again, how this has been described since the 80s, and how with that framework of prevention, how it affects so many things from an individual level out to a societal level, and how all these policies and different things going on in the community, how those play a role in terms of either maintaining or addressing and solving and curing violence, if you will. And so for us, we understand this framework, and a lot of that framework is addressed with having a strategic approach in terms of how we started a lot of things, the efforts around DLive. And one of the things that was very important was really just understanding the community and really the grassroots kind of efforts that were being done, and really getting a pulse in terms of what was going on. And I think Ray can just even speak to some of that, just briefly around some of that engagement and how, you know, some of those experiences in the community provided us, you know, a pulse of what was going on.
So once going into the community, what we found is traditionally when we think about direct service provider organizations, a lot of times the information don't get down to the community, right? It stops at a lot of times the organizations being acknowledged with handouts, right? Traditionally, folks give out handouts, things like that. When we got off into the community, what we found was the information that we had from the public health lens, a lot of community members just didn't have the information, got excited about the information. I just use ACEs, for example. Being able to go out and understand the adverse childhood experiences and the trauma that's been associated with it. The moment that we started giving it out to community members it was a lot of community members that was like, aha, so this is what's been wrong with me. It wasn't what I've done, but more so what had happened to me in my brain development. And so imagine young men and young women in the community aged 16 to 24 who traditionally would be in the neighborhood not understanding PTSD, not understanding acute stress disorder, not understanding and having the information to explain and express trauma, diagnosing each other, saying, man, your signs are showing PTSD, right? So again, that was just some of the information that we was able to explain, give out to the community, and started having community listening sessions, and it just started spreading like wildfire.
Right. No, absolutely. So, conversations like that around understanding what's going on the grassroots level in the community is part of that, those initial conversations that you want to start having, just to understand how people understand this issue that, you're getting ready to address. The two individuals at the bottom there, as we think about other strategic stakeholders in this process in terms of initiating our work, you have the CEO of our hospital, and really somebody who knows the community very well and has had various roles out here, in Conrad Mallett. And then you have Dr. Brian O'Neill of the chief of emergency medicine, the Department of Emergency Medicine at Wayne State Hospital. And their pictures both represent the important roles that having engagement from the healthcare leadership, healthcare executives, and from academia, the role that they play in terms of really anchoring this work in terms of what we're doing. We know that health systems are oftentimes the biggest employers in terms of people in the community. They're an anchor in the community. They provide so many resources in terms of health promotion. And when we start talking about violence and looking at it through a health lens and having a health-centered approach, it's obvious and clear that you need to have health leadership and systems really aligned with that work and in support of that work. When we talk about violence and really looking at it as a chronic recurrent disease, it's important that it's elevated with sophisticated scholarship and investigation and a rigor, and therefore that's the importance of having academia really integrated into this work as well. So when we think about this sort of community, health leadership, and academia, that's really a strategic triangle, if you will, in terms of just part of the initial efforts that are necessary in really addressing this framework of prevention and violence. And when you look down here in terms of the key approaches, I think some of the key takeaways to take away from some of the stuff that we've done that has brought us some, success and kept us sane is really starting small, right? Understanding the importance of starting small, having clarity in our mission, and we'll go from that. We'll talk about that later. And then really knowing your audience, right? When you heard Mr. Winans just speak about an example around how community has responded to some of the information that we share with them from our body of work, that's really knowing the audience, right? And knowing what people need, knowing what the gaps in information are. And so this slide, again, just kind of representing some initial efforts around how to create systemic solutions for a systemic problem and some critical strategic stakeholder engagement. Moving over here, I want this slide here is really something, again, to inspire people around understanding where you are, right? Understanding your local community. I know when we first started out with DLive, it was very important to understand who are the organizations that are working with this problem, who are the people, who are the leaders that are working with this problem, who are trying to address this issue, where are those tables being convened, right? And really paying homage to the leaders that were out here in the community and taking time to listen, to really listen. I think when it comes time to creating something that does not exist, in a community or in a situation, you really want to know who's been doing it already and how you can further sort of enhance or help them. And we really try to be driven by data as well, and that's what this slide off to the right shows. There's a great organization out here called Data Driven Detroit, and I just sort of borrowed this from them just in terms of how they do some of the city planning and how a lot of decisions and things ought to be influenced by data in terms of what's going on in certain neighborhoods, and understanding that Sinai Grace being over here in this sort of northwest section of Detroit is much different than what's going on down here along the riverfront or in southwest Detroit. But there's also similarities in other communities, like what may be going on the east side. And so really just taking the time to understand that and understanding how these different conversations and things are being had in the community. I think Ray and I were having a discussion even yesterday around some of the history around violence and kind of understanding what was being done in the city prior to the arrival of DLive. And understanding that is key, right? And it's been key for us just in terms of understanding how we want to move. I think, Ray can share just even one example in terms of how violence was being addressed in the city prior to DLive.
So prior to DLive, the only way to address violence was from a public safety lens and not a public health lens. And too often, the public safety lens will become punitive because it's not considering the trauma that's associated with the individual who had been victimized. And so prior to DLive, every victim, for lack of a better word, would be also treated as a suspect, especially if they were young men aged 16 to 24. The moment that law enforcement would respond to the hospital, it was traditionally, what gang are you in, who shot you, and things like that, get patched up, stitched up, and then sent back out into the community. Well, once DLive came into existence, that language started to change. Instead of law enforcement actually coming to the room to ask the questions, DLive would be the first responder. Then we put together a meeting with the chief of police here in the city of Detroit and let them hear from some of the individuals who had been directly impacted by the violence, guys who had survived shootings. And they had an opportunity to address the way law enforcement would respond. And so we coined it bedside manners. And so the chief ultimately understood it and then started looking at victim liaison officers to respond and allowing our guys through DLive to lead the conversation and the training with these officers on bedside manners and bedside approaches.
Right. And so, yeah, there's an example there in terms of how, again, what the landscape looked like, prior to DLive, if you will, right? And some of the things that still exist around, community approaches to violence, right? With regard to the health system approach to violence and community violence, right? From a trauma center standpoint, there was really not much of anything, right? A lot of times what we had,
not much, it wasn't.
Right. A lot of times what we had was, you treat the physical wound and you send them back out into the community. And a lot of times what has been done as it relates to trauma centers and dealing with violence is, there may be some educational initiatives that are done where you maybe take these scared straight approaches and you bring children in to come and see the morgue, or you might bring children in to come and see the trauma center and say, hey, this can happen to you if you don't get things together and don't get things right. And, the research quantitatively and qualitatively has shown that that's not really the best approach, because not only do you have children that are already familiar with that and aren't scared of that, but you also add to some of the stress and, previous adverse memories that they may have from experiences that they may have had with that or other family members, or you might have had approaches where people might have gone into schools to go give a talk about bullying and things of that nature. And while that's important, again, it's really not the health system kind of health-centered approach that really addresses the issue really head on when you're dealing with a young man or a young woman who's just been injured. So really just understanding, again, what's going on in the community, understand where the gaps are and maybe where some of the misinformation is. But again, most importantly, just listening, assessing the situation, and paying respect and homage to everybody who's already doing the work, or who is already working in that space, I should say. Now transitioning over to part two in terms of we talk about strategies around building community partnerships and leveraging certain resources. I want to take the time for us to really just pause here, right, and really just have a hard stop, because this is a pivotal point of meditation. and really just understanding this, this issue of equity, and this issue of equity and how that really anchors the work that DLive does. It anchors the mission of our work. And as a result, everything that comes out of that, whether it be the design of what we do, the decisions that we make, our mission, everything is really rooted back in terms of equity and social justice. And so when we're talking about equity and social justice, that really helps us to really reframe this concept around violence, right? It changes the perception on how violence is viewed. Because if we're looking at things from a health issue, we understand the importance of people having equitable opportunities at being healthy, right? And understanding that violence is preventable, and really being able to lift up this concept of accountability towards all the community partners and different sectors that are in the community that really touch this issue of violence, right? Again, going back to that framework of prevention, whether we're talking about the judicial system, whether we're talking about schools, whether we're talking about any of these things, this concept of health, this concept of equity, and this concept of social justice really help to align things when we're dealing with issues of violence or any other thing that disproportionately affects different people. And so when we talk about equity, we're talking about health equity, right? We're talking about racial equity, and really understanding that's something that we can't shy away from, and understanding the role that plays in terms of creating, ways in which people are disproportionately affected by certain things and chronic issues. And so that's something that, as an organization, that you really got to be really ready to take on and really address in order to, I think, for this work to be centered in the right way. And for people who work with you and who support you, they have to understand that as well, because, again, it helps to align those resources, and it dictates how some of the relationships that you may have, how they need to change in order for them to work the right way there. So, again, I think this kind of bridges the first part and the second part of our presentation around making sure that you guys are applying, in terms of making sure that the proper lens is applied to this work. When we talk about collaborations here, this is really such a key part in terms of anything that we're doing. And I think that goes without saying. We'll talk a little bit about some of the collaborations here locally and nationally that have sort of helped us in terms of being able to really achieve our mission in terms of what DLive does. And again, when you go back to that last slide in terms of looking at equity, that means that we know kind of the different organizations that are in the community that we're looking for, and the different characteristics that they're going to need to have in order to work in the space that we're working in and to achieve some of the goals that we're looking at achieving. I can start off just by mentioning, first of all, just the Detroit Justice Center. I encourage you guys all to read up on that when you get a chance to. And Detroit Justice Center is something that works around creating equity around justice-involved individuals, people who may not be able to afford bail, issues with land, and really just creating a just, equitable city. And when we talk about justice-involved individuals, we understand that that's something that a lot of folks, especially when you're talking about like economically and socially challenged areas, that's an issue that needs to be addressed. And so they've been a great partner in that in terms of helping us address some of those issues with some of the things that we're doing. And again, we'll get to that in terms of some of the case scenarios there. Ray, in terms of flip the script?
Yeah, so what we here at DLive, we had was just pretty much go out into the community, do a landscape of individuals who was doing direct services. And so we came across Flip the Script. And so once we went through Flip the Script, and what I mean by we went through, we actually sent our participants, some of our members, through the process of what Flip the Script does, and allow them to vet the community service partners, right? Making sure that they can provide the services that they said they can provide. And so we just decided to bring everything in-house, utilize Flip the Script for educational opportunities, transportation, and direct services. And so it's been a great partnership as it relates to local community organizations here in the city of Detroit.
All right. And again, I think one of the things with Flip that's been, again, knowing what we know with them, they've worked with returning citizens, if you will, so people exiting out of, trying to reintegrate into the community out of the criminal justice system. And again, because of some of the overlap in terms of the challenges that people deal with there, they were they were an obvious partner in that regard, right? And we've had to, have discussions in terms of the best way in terms of how that work needs to be oriented. And there's several other organizations out here that kind of help to illustrate the importance of how these relationships need to be aligned. One of them include even the Detroit Hispanic Development Corporation. They've been great in that regard. I think even when we talk about local communities, right? Communities also don't have to necessarily extend outside of the walls of the hospital, but even the local community and the collaboration and the support that we've gotten from our trauma surgery team, and they've been great just in terms of always reaching out for, hey, what do you guys need, and support and things along those lines. And so that's been an important community collaboration just internally. Would you agree, Ray?
Oh, most definitely, because we can't. It's a lot of things that we just didn't have in our wheelhouse, if you will, that the trauma surgeons actually stepped up to the plate and said, hey, you know what? We love what you guys are doing. This is the best thing that we've ever seen implemented as it relates from a trauma surgery lens. It's better than scare tactics and things like that. And I think the greatest impact for the trauma surgeons, primarily Dr. Seaman, Dr. Atwell, and Dr. Brownwell, is seeing some of the guys that they actually worked on in those in those operating rooms, and then to see those individuals come back up here, whole, healthy, smiling, well-grown, employed, in school, and saying, hey, you know what, I remember when you saved my life, and thank you. That right there was the game changer for the trauma surgeons.
Yeah, absolutely. And so even when you talk about neighboring communities, I mean, we can kind of get into this a little bit later. But right, just with like, maybe a quick example with.
So even with the neighboring communities, so again, keep in mind, D-Live is the first and only hospital-based violence prevention program in the state of Michigan. And so we've been blessed and fortunate to receive funding from the state. With that funding, we've been able to ultimately establish relationships with Flint, Battle Creek, and Saginaw. So Saginaw and Battle Creek are next up for us to provide TA support in them developing their hospital-based violence prevention and violence intervention programs as well. And so we've been able to expand it across the state and ultimately doing one training in Newark, New Jersey, and helping them establish their first hospital-based violence prevention program out there as well.
Yeah, absolutely. So, yeah, the importance of this, collaboration in different communities that may be, again, experiencing some of these same things has been huge. I mean, we've had people come out from Boston to come and visit us where we're at here. And I think what this does, it really amplifies the urgency of the work, right? Once you start talking about this stuff and you're seeing, other situations in other communities where they're dealing with this, and them having, the interest in terms of coming out and seeing how we've been able to do some of the things that we've done here, I think it really amplifies the urgency of the work. Moving forward, social determinants of health. I think that is something where if you're tuned into this webinar, most people are probably, familiar with this concept, and it's simple in terms of understanding, conceptually, and that's really, hey, what are the social determinants of health are essentially, in its simplest, most basic form of understanding, are the economic and social conditions, right? The influential economic and social conditions that really influence an individual's and a group's differences in terms of their health and their well-being. And you'll see from these two different graphics here, one being a little bit more illustrative and one being more text. But they talk about, by no means are they exhaustive, but they talk about the majority and the most common sort of social determinants of health that play a role in terms of keeping people healthy, and when there is perhaps a lack or a misalignment of some of them, how they can contribute to adverse experiences and poor health outcomes. And so they're important to understand because they're going to help you really align your work and really understand how the community needs to be looked at, right? One of the questions we always ask ourselves continuously, and it was important at the beginning of this work, was, hey, do we have a community that has resources that are responsive to people that are emerging from community violence, right? A lot of resources that may exist in your community may have been set up historically to respond to perhaps foster children, or perhaps domestic violence, or alcohol and narcotics abuse, right? But because community violence hasn't really been something that's been really thrust in the public consciousness yet, in terms of really understanding and looking at it as a public health issue, a lot of times the resources are not aligned to really coexist and to serve individuals and the needs of the people that are coming out of community violence situations, right? Because again, as Ray kind of mentioned, a lot of times for your communities, you could probably attest to the fact that there's an over-reliance on law enforcement and criminal justice systems in terms of responding to issues of community violence. But I think what's been shown over and over again is that this is not an issue that we can simply arrest our way out of, right? And there really needs to be a health-centered approach and focus to that. So again, that's where the importance of understanding social determinants of health really comes in. And again, whether we're talking about violence, heart disease, diabetes, whatever it is, arthritis, again, social determinants of health are going to be key in terms of understanding that. And again, when you look at things from, again, that social justice, racial equity, and health equity lens, it lets you know that not all resources in your community that have to deal with social determinants of health may be for the individuals that you're working with, and that's vital. And that's going to be very key to understand. And as Ray mentioned, I think one of the things that's been super important for us is this concept of vetting resources and really making sure that we don't just send people to places, number one. Number two, we take the time to, if we need to create anything internally, we'll go ahead and do that. If there's not a resource out in the community that can really adjust things the way we need it to be. But also never just sending a guy somewhere, but going with that person, right? Going with that individual to see what's going on and how something may look. Ray can share just very briefly one example in terms of vetting a resource.
So we had a group of young men, again, young population, African-American males, who we had spoke with and encouraged to seek therapy around the issues of PTSD, their mental illness, and their safety being interrupted with the act of violence. And so through that process, we took these individuals. I gave the service providers my information. I went through the entire process with these guys, right? Bill me, right? Because I need to see the therapist. We believe in leading by example. The process was real tedious. It was very time-consuming, and it wasn't any trauma-informed practices used, right? No trauma-informed language. So I was listening to all this, and in fact, it was a waste of time. But because we went and we truly understood the process, we were able to look, check the landscape out, bring everything internally, and say, you know what, we'll bring mental health into our wheelhouse, right? And so, but through that process, we actually ended up losing one of our guys by taking him over there because it didn't represent and it didn't look like, and it wasn't the culture from what these young men had been experiencing, right? Going over there, we had a lot of people who was dealing with, in that environment, dealing with substance abuse, alcohol. Some had dual diagnosis. So you have a 16-year-old that's looking at a 35-year-old man who's been on abusing substances and drugs and homeless for the last 20 years. He's looking at him and saying, I don't look like him, and so therefore I don't need the help that he needs, and this is the wrong place for me. It wasn't culturally relevant for these young men.
Absolutely. So yeah, so really taking the time to understand and going in there and peeping these resources out there. And making sure that they're responsive to the culture of your organization and what's needed. I want to make sure we leave enough time for questions, and so if it sounds like we may be speeding through a slide, forgive us. We can always go back, but we're going to touch on just two examples here in terms of some case scenarios. I'll share one, and I'll have Ray share one around how some of these social determinants of health have. How we've leveraged some of that and how it sort of played a role in some of the in the health outcomes of the individuals that we work with. Just quickly, there was an individual that we met in the first year of our work that had been great kid, and he had been the victim of a shooting that happened just down the street from his home, within no less than 2 minutes walking distance, just right up the block from where he lived. And we met this individual. Ray had met him. He started working with the team. There's a lot of very high intent engagement and outreach early on. And one of the things that we noticed was that there was not a lot of movement that we were seeing in terms of his progression, in terms of some of the highlights that we kind of look for. to really transform his trauma, if you will. And when we took a step back and just sort of looked and analyzed what was going on with this young man, we really had to go into the home and really sit down with him and his family and really understand all the different levels of trauma, not only the current acute trauma that he sustained, but the family trauma and the generational trauma. And some of, again, when you go back to that framework of prevention that Ray spoke on earlier in that interpersonal thing and talking about the social network, some of the trauma that some of the family members were going through. And what we realized is that, hey, you know what, there's a lot of PTSD going on, not only from this guy's injury, but also PTSD just in terms of all the trauma that they've been experiencing. But more importantly, I think the thing that was very acute at that time was the trauma that he had experienced from the shooting that just happened right down the street from his house. It necessitated an urgency on the part of his mother and really him that they needed to move. This is a young man that wasn't interested in coming outside. There was fear in coming outside. Whenever time maybe a car would come to a screeching halt, the mother would be worried that there was going to be another shooting. And so you can imagine, if you really understand that some of these components of PTSD around hypervigilance and paranoia and disruptions of sleep, that's going to interrupt somebody's whole way in terms of activities of daily living. And so it became imperative and urgent where, like, hey, you know what? Their housing situation was a social determinant of health that was playing a critical role in terms of them not being healthy and them being unable to function. And so as a result, we had to really utilize the different resources that we had and really look at the community and say, like, hey, what is out here in terms of housing and how we can help to relocate this family? Not that they were homeless, but that housing was insecure in terms of where they're at right there, and it was worsening the mental health and wellness that they were experiencing in that time. So it became very imperative that relocation was key in terms of, before anything, before looking at, whether he got a GED or education or employment, it's like housing was the priority then. We had to look and see what existed in the community and some of the things that we needed to do and take on as an organization personally to achieve that as a goal. And we could talk a little bit further about that later, but that's just one example of in terms of how housing and PTSD and mental wellness sort of played a role in there as well. Yeah. Okay. And, and I think one of the other things, there's been countless examples where Detroit Justice Center and some of our other criminal justice partners have played a role in terms of, whether somebody may have outstanding tickets and things of that nature that may impede their ability to get a license and then, again, become, to be able to engage civically back into the community and pursue things like a job and education and things of that sort. And so really understanding, what the justice-involved landscape is out there around partners that are aligned with this mission of equity in your work. Transportation's played a huge role for us as well. And we understood that we couldn't just simply put individuals maybe on a bus and give them a free bus ticket and say, hey, we're achieving our goals in terms of, transportation. We really had to be trauma informed and understand that, hey, you know what, if somebody doesn't want to leave their house or if there's issues going on with community conflict, it's not safe for somebody to be maybe going out to a bus stop on their own, and different things that we had to do in terms of creating innovative and creative solutions around transportation, right? Because we don't live in New York. This isn't Philadelphia or Boston where we have that sort of integrated public transit system that makes things easy. So again, we had to adapt and really figure out this concept of transportation and how that played a role in terms of people's health.
And this is Ray. I'd like to add, with that transportation, we always were curious on why other organizations' retention rate was pretty low. And so through that, when we decided to use Lyft and Uber and community-based transportation, we noticed that traditionally the individuals who would traditionally cancel appointments, they would actually make the appointments because the ride was pulling straight up to them and picking them up, dropping them off. Uber and Lyft is pretty fast, right? And so we couldn't we refused to apologize about what it is that we needed. And so we just had to start talking to our funders and our investors and letting them know, hey, our transportation budget is probably going to be the biggest budget out of every facet of the social determinants of health budget. And we didn't apologize, and that alone allowed us the opportunity to get our young men and women services that they needed as well as their families.
Absolutely, and I think that being unapologetic, right, in terms of, because when you're centered and rooted in the work and you're really, and the voices of the young people that you're working with are centered in that, then you know what you need to do as an organization in terms of serving the community that that you're serving. And so, yeah, for us, I think one of the takeaways with this work is it's not always pretty, and it's for us at D-Lab, it's definitely not checkbox sort of work, and there's a lot of real vetting and real innovation and sitting down and figuring things out in order to make what may be an inflexible community and bending it towards flexibility to really align itself with this sort of new mission and this new way and this new culture of health around what you're doing. And so that's a good segue just in terms of us, in terms of how to create platforms for community voices and stories to be centered and heard. I think when we're entering the space around how to center voices and community experience and stories, it's important to really just again just sort of really meditating on the mission and the spirit of the work. And when we look at things here with D-Lab, that's what we always try to do, and I think this quote that comes out of some writings around these philosophical teachings of the Stoics and Stoicism and Cicero and things of that nature. I think this quote right here really helps us in terms of understanding how we move and how we value the importance and the existence and the humanity of the young men and women and the community in general that we work with. And so, again, when we're talking about creating platforms, it's just important to really just be centered in your mission, because if you're not, I think a lot of things are going to be misaligned and maybe missed opportunities around really achieving, effective outcomes for such a huge major issue that's been either mistreated or untreated for so long. I think for us, when I look at our mission. I think some of the questions that we always have to ask ourselves is what we're doing, is this research-driven or is this service-driven? Right? It's a question that you have to ask yourselves when you get into this work, because we're not research-driven. Is this a law enforcement sort of led or a law enforcement heavy thing, or are we understanding that, again, this is rooted in health? Again, important things to always consider and bring that thing back to, right? Understanding that we're rooted in trauma-informed care, that we're rooted in understanding this concept of resiliency and people's transformative potential. And so that helps us to really hone in on the existence and really recognizing and acknowledging the existence and the humanity of the people that we're working with. And I think it really sets the tone and it signals to the people that we're serving, hey, you know what? We trust D-Lab and what they're doing, right? We trust the work and the organization, and they have our support, right? It helps us to really engender a great rapport, and then we're able to have authentic engagement. And I think that's what you'll see over here in these next few slides. I think we just really get authentic engagement because you allow people to be their true authentic selves. And so when you look at this is just one example here. When you two examples really. When you look to the left, this was back in 2017 where there was a conference that we spoke at, around resiliency and hope through trauma-informed care. And whenever we are able to, and if the opportunity allows and resources and just, logistically we're able to, we always want to bring the young men and the young women that we're working with to allow their voices to really shine through, because that's what our work is revolves around. That's what we learn about. That's what we learn the most from. A lot of things that you guys are hearing from here, we've learned from our best teachers, and those are the individuals and the young people and the young men that we work with, right? They get a chance to contribute to the growth and the design of the organization, right? It's an opportunity for them to learn, right? So when they hear us giving a talk on, building a safety net around community violence or encouraging resiliency, there's also a passive learning that's going on as well as they watch us speak and present, and then we're able to turn the microphone over to them and they're able to articulate their experiences as well. So taking advantage of speaking opportunities, conferences, and panels, again, to really center the voices and experiences of those who are closest to the problem, quite frankly. I think to the right, what you'll see is just a speaker bio from, again, there was a community panel, a conference, and one of our guys was a speaker, and he was featured as a speaker on the panel. And so this was, we changed some things around so it's not identifiable. But again, just professionalizing his experience, right, and him as a community member. And so really going through that and really taking this concept of asset framing in terms of something that's that you'll see really led by Travian Shorters. Go ahead, Ray.
Yeah. So I'm part of a network called BME, Black Male Engagement. The founder and CEO is Travian Shorters, and he's trained on asset framing. And so when we look at asset framing, traditionally with direct services, when an individual come in to do an intake and an assessment, it's traditionally, hey, is this your first time being shot? Do you have a GED, high school diploma? So do you have children? So they asked all these questions, but nowhere on the questionnaires from what we have observed and the questionnaires we collected from other service providers, was it a space on there that said, hey, are you a great father? What are some of the greatest assets? What are your strengths, right? And so we pride ourselves on being an asset framing, trauma-informed organization. And again, we received that information from BME. And that right there alone is what professionalizes our guys' experiences, like Dr. Shanui is talking about. When you see their bios and things like that, what they've been through is worth something. And so we make sure that we allow them the experience and exposure and the opportunities to speak in an authentic way about their experience.
Yeah, and also to compensate them for their time when they do come and speak as well, to give them opportunities to earn and really understand their value and their time and their experience as well. And so taking that opportunity to continue to educate them as well. And again, we're sharing this here as well in terms of, again, when there was a recent LA Times feature, I think, in the summer. And again, just really taking that opportunity to really put the young men and young women and their families and things that we work with to be able to share their story, right? Is a means of empowerment and resiliency and letting them know that they always have something to contribute to this space. And so, we value that, and we know that, meaningful engagement and participation, that engenders resiliency. And when we're talking about building community resiliency and individual resiliency, I think that's really how you start to move the needle forth in terms of creating this culture of health around community violence and really moving the needle on this issue that's been so stubbornly persistent and ingrained in so many communities here. And just closing out, it's just important, again, always to think about what success looks like in this work, right? I think traditionally, Ray kind of mentioned, are we looking at success in terms of, hey, somebody got, a GED or they got employed, and all that stuff is incredibly important, as we mentioned, as it relates to social determinants of health. But understand and appreciate the process, right? Understand the process in celebrating. I don't know where my pointer went. Oh, here it goes. But understanding that, this right here might represent somebody finally leaving the house and going to maybe get a haircut, right? Or maybe their substance abuse has really gone down, tremendously in terms of like their alcohol or prescription pill, abuse, right? Just understanding that this is success as well. This is success as well when somebody finally accepts, like, hey, you know what? The wellness of my mind is equally, if not more important, is the wellness of my body as well. And I'm going to take the active effort in terms of getting engaged in that process. And so really getting as an organization, it's going to be important when you all are engaging in this work to understand and really get to the root of what success looks like, and really redefining what those outcomes are and holding steadfast in terms of not falling in line with what traditional outcomes look like. So at this point, we want to stop because I know we're getting close to the end, and so want to take the time for our moderator to go ahead and field questions. Thank you guys for your time.
Thank you, Dr. Tolu Shonui and Ray Winans, for your presentation on the complex issues surrounding community violence. We'll now begin the question and answer portion of today's event. As a reminder, you may submit a question for our speakers in the question and answer box to the left of the presentation. Simply type your question in the box and hit submit. Our speakers will answer as many questions as possible in the time remaining. One of our questions is, has Sinai Grace implemented a broad definition of reportable violence within the hospital setting? And is this definition utilized for data gathering purposes?
So good question. San Grace is part of a a consortium like the Trauma Surgery Center. There's like a trauma registry, and there's records and things kept around around different types of injury, and the trauma activations, and they're part of a network of other trauma centers where that stuff is shared, and things along those lines. So yes, this information is recorded, if I'm understanding that question correctly.
Thank you. Do you issue no trespass notices?
Can you define that a bit better? No trespass notices to who?
I'm not sure. It was a question that came up about the issuance of no trespass notices. So could be potentially those that are perpetrating violence on other patients, staff, those in your program. Is there any type of policy of that sort where you would do something like that?
Yeah, so we personally, D-Live, we don't issue a no trespass kind of thing. The hospital security system, just in general, there's a general culture of, somebody who is a patient who is recovering from something has the right to determine who is on their visitors list in terms of who can come in and who cannot come in. So there's that policy that exists there. One thing on our end is that we share with our individuals that any information that they share with us, we have some protections around that information cannot be subpoenaed, and so we definitely make sure that we communicate that to individuals that we work with, and just letting them know again that we're not law enforcement, and again we're interested in their health and their healthy being and their outcomes. But in terms of D-Live and the no trespassing thing, we don't issue anything along those lines. But our hospital security team, they do manage people's guest lists and things like that.
Okay, and you mentioned that mental health services, you decided that you had to bring them in-house. Are there other services that you decided when you were vetting the services on the outside, that those would be better provided in-house?
Yeah, I think there's been a couple examples, and sometimes it ebbs and flows just in terms of what's going on or for the individual. Some individuals may need their education, some of the tutoring and things of that nature to be convened by people that we're able to personally bring in and provide tutoring, or if they need to do some online schooling and providing a laptop and a space for them to kind of, achieve and make progress in terms of some of their education goals if they're like on a GED program. I think transportation, like Ray mentioned, was an example in terms of we couldn't rely on, maybe public transportation systems, or if another organization offered, hey, D-Live, we have bus tickets that we give out. We get, no, you know what, we're gonna figure it out on our own in terms of how transportation best looks for the individuals that we work with. So those are a couple examples there in terms of some other ways that we've had to do some things internally around education and transportation.
Can you describe a little bit the mental health services that you've ended up providing? There seems to be a lot of the family, not just the individuals that are directly in your program. Can you share a little bit about the scope of those services?
Sure.
So we have we have our trauma peer support group, right? And how is Healing Our Women, where that's led by the therapist and our violence intervention specialist, the women violence intervention specialist. And so with how they actually work with the young women in our program and the spouses, the mothers, and the grandparents, and any other women who's directly connected to the young men who have been exposed to violent trauma. And then for our men, we have our trauma peer support group that's led by myself, Calvin, and the therapist as well with our social work team.
Thank you. That concludes the time we have available for questions All attendees in the next few days will receive an email that will include a link to the archived webinar session. We want to thank our audience for joining us. We want to thank Dr. Tolulope Shinui and Ray Winans for their presentation and sharing their experience on violence intervention programs. And I just want to say that at the conclusion of the webinar, you'll see a brief evaluation pop-up on your screen. Please take a minute to complete the evaluation so that we can continue to serve you better with future educational programs. Thank you again for joining. This concludes today's program.
Ladies and gentlemen, that concludes today's webinar. You may disconnect your phone lines, log off the webinar, and thank you for joining us this afternoon.